My name is Klaus Grafhold. I'm a professor of endocrinology and molecular medicine at Aarhus University Hospital in Denmark. And we have a large Turner syndrome clinic, and today we're going to talk about Turner syndrome. I'm going to address especially adulthood with Turner syndrome and discuss with you some of the comorbidities that we see during adult life. But I will actually start by addressing the genetics of Turner syndrome just shortly, because that is the basis for what we have to deal with in Turner syndrome. You could say that it is simple, because most girls or females with Turner syndrome miss an X chromosome, or at least part of an X chromosome. But it turns out that it is not simple at all. And new data are emerging during these recent years, pointing towards a much more complex picture than we have hitherto thought. And so I think an understanding of the genetics of Turner syndrome is really necessary in order to understand all the intricacies of the phenotype that we see in Turner syndrome. So what do we know? Well, normally a female would have 2 X chromosomes, and one, of course, as you know, will be active and the other one will be inactivated, or at least most of that X chromosome. We also know that under normal circumstances, the inactivated X chromosome can be seen as the bar body, and we know from recent research that it condenses and becomes to heterochromatin and is covered by the exist RNA. But we also know that on the inactivated X chromosome, there are a few genes that escape X inactivation. We call these genes for escapees. And the genes that escape X inactivation are, of course, one of the, they can be seen as candidate genes to have an influence on Turner syndrome. But we also know that just like on the Y chromosome, there is a PAR region, or the pseudo-autosomal region, that sits on the tips of the Y chromosome, and a similar region is situated on the X chromosomes. So genes in these regions are normally expressed from both the X and the Y chromosome, and in normal females, they're expressed from both the X chromosomes. So genes residing there may also play a role in Turner syndrome. And so genetics until now has shown us that the SHOX gene, which is situated on the PAR region, is responsible for some of the phenotypic characteristics of Turner syndrome, while the other regions, the lymphogenic region and the ovarian region, is simply still something that we hypothesize are located where I have indicated them here. The SHOX gene was discovered many years ago right now, and we know that it is responsible for some of the phenotypic characteristics of Turner syndrome, especially the shortened final height that we see in Turner syndrome, but also some of the other consequences of Turner syndrome, as you can see on this slide. But since we discovered, or that the SHOX gene was discovered, we have been looking for other genes that have until now eloped our discovery. We recently published a paper where we showed that there was widespread hypomethylation in the entire genome of Turner syndrome females, not only situated on the X chromosome, but really extended to the rest of the genome. And this led to pervasive changes in the transcriptome as well. So we think that this widespread hypomethylation also plays a role in Turner syndrome, but exactly which genes are involved and which mechanisms are involved, we still don't know. And this has led us to propose this model of Turner syndrome, where we see the missing X chromosome, and we have listed some of the the genes here that are candidate genes for some of the changes that we see in Turner syndrome leads to this altered hypomethylation or methylation profile, which then again leads to changed RNA expression, again leading to changed protein expression, and that this might explain some of the phenotypic characteristics of Turner syndrome. So we can now say that there are changes at all levels of the genome, the epigenome, and the transcriptome, and that multiple pathways seem to interact in complex ways, linking different signaling pathways to different diseases that we see with increased frequency in Turner syndrome. And we think that a deeper understanding of, for example, congenital heart disease, malformations in Turner syndrome could lead to new treatments. We now realize that it will be necessary to study multiple tissues and cells, and that also temporal questions such as when do these changes appear in fetal life, in childhood, or in adulthood, will lead to new discoveries. And we could also see different parts of the phenotype in Turner syndrome as a model system, perhaps. For instance, the frequent occurrence of type 2 diabetes or spontaneous abortions, growth disturbances, and so on could be seen as models that we could for how to expand our knowledge on Turner syndrome. But returning to what it is all about with this genetic background in mind, what is it that we want to achieve in Turner syndrome? Well, we want to reduce the increased mortality that we see. This is British data and Danish data in one slide here. As you can see, there is an increased mortality in Turner syndrome, leading to premature deaths, and this is caused by many different diseases in Turner syndrome. Congenital heart disease leads to a number of early deaths, aortic dilatation and dissection, but also endocrine diseases and respiratory diseases and other diseases, as you can see on this slide. So this means that the morbidity in the patients that we see with Turner syndrome is something that we have to deal with in order to reduce this increased mortality. And then we also have to talk about diagnosis, because even though most, especially perhaps pediatricians, think that the diagnosis of Turner syndrome is easy, it is really not so. These are Danish data, but they're also Swedish data to show the same, namely that even though many think that Turner syndrome females are diagnosed already in childhood, this is not the case. The median age at diagnosis in Denmark is 15 years, meaning that half of all females with Turner syndrome are really only diagnosed after the age of 15 years. And this also leads to unrecognized morbidity and perhaps even unrecognized mortality. And how many do really suffer from Turner syndrome? Well, we know that from previous chromosome surveys, about 50 for every 100,000 females will have Turner syndrome. That means that we should have about 1,400 in Denmark, and I can tell you that we've only diagnosed about 1,000, so we're missing about 400 in Denmark. And we should find about 115,000 with Turner syndrome in all of EU, and about 100,000 in the United States of America. But we know from Danish, Swedish, and UK data that this is really not the case. As I told you, we have not diagnosed all with Turner syndrome in Denmark, and we have calculated that the relative percentage is really only 67%. When we look at Swedish data, we can see that only about 40% of the expected numbers are diagnosed. And when we look at UK data, we can see that only about a third of all expected Turners are diagnosed in the UK. So underdiagnosis is frequent. And this is a slide that I took from the recent international guideline on Turner syndrome, and as you of course know, most typical characteristics are short stature, hypogonadism, infertility, perhaps hypertension, hypothyroidism, middle ear complications, and hearing disability. But really there are a lot of other characteristics that we see more frequently in Turner syndrome, and these are presented in the table here, and I'll not go through that in detail. But even if we have all these characteristics, as I said, I don't think the way we diagnose Turner syndrome today really works, because we simply do not diagnose everybody. So we have discussed, and I'd like to pose that to you as well, should we screen the entire population, or should we screen at least a part of the population? And could we increase or improve the surveillance by general practitioners and school nurses and so on? I really don't think so. I think the only way to diagnose all Turners would be to include that on the heel prick test that we use on newborn babies. But that is something that has not been implemented anywhere in the world so far. So I told you that mortality is increased in Turner syndrome. These are British data, just to show you that there are multiple different causes: nervous system diseases, cardiovascular diseases, digestive and genitourinary system diseases, and specific causes as epilepsy, ischemic heart disease, aortic dissection, and so on. Interestingly enough, cancer is not increased in Turner syndrome and does not lead to increased risk of death in Turner syndrome. And in this British study, they did not find any deaths due to gonadoblastoma, which is something that has been discussed a lot in Turner syndrome. And these are some Danish data just showing you the background population, which you can see as the smooth line, and then you can see all the different karyotypic groups in Turner syndrome, and you realize that while the 45X group has the highest mortality, also all the other karyotypic groups has a higher risk of mortality. And these are some brand new data that we just published this year, just showing you the hazard ratio for the different karyotypic groups, just underlying that the risk of early death when you have 45X is quite increased to a hazard ratio of 4.7, but also all the other groups, in all the other groups you see an increased risk of early death. What do we do in the clinic? Well, thyroid disease is frequent, and that's why we screen every year and test everybody that comes in the outpatient clinic. We can see from this Swedish study that when a female with Turner syndrome reaches the age of 50 years, about every second woman with Turner syndrome will have thyroid disease. And this is also confirmed in other studies, and we can also see it in our clinic. Endocrine diseases on a whole is increased. These are some Danish data just showing you that type 1 and type 2 diabetes is also increased, and as I said, thyroid disease is also seen with increased frequency in Turner syndrome. This is a study we did some years ago, just focusing on the risk of osteoporosis or decreased bone mineral density. In this study, we looked at 54 adult women with Turner syndrome, optimized their treatment as much as we could, and we, during a 5-year follow-up period, could actually see that this middle-aged population could increase their bone mineral density, especially when we look at the spine. Just emphasizing that even though you have an adult woman, you can still optimize her treatment. And we concluded that for bone, there doesn't seem to be a window of opportunity, meaning that you don't necessarily have to start treatment as early as possible, although we of course recommend that. But even if you improve treatment later on, you can still win a lot when it comes to bone. Hypertension is also frequent in Turner syndrome. These are some data from a British study where you look at children. In the one panel you see young children, and in the other panel you see from 13 to 18 years of life. But you can see that even at this age there are cases that have a higher blood pressure than expected. And when we look at adults, it becomes clear that many will develop hypertension. This is a study we did many years ago where we intervened and either gave placebo for half a year or HRT, meaning estradiol and a progestin, and during treatment with hormonal replacement therapy, HRT, we did actually see a reduction in blood pressure. And this has been shown by other groups as well, and we have recently done a new study showing exactly the same, that HRT reduces blood pressure in this normally premenopausal age group of women. And we also concluded that there wasn't a window of opportunity when talking about blood pressure. This is a study of young women aged 15 to 25, and we followed them for 5 years and gave them either estradiol 2 or 4 milligrams for 5 years, and it did not impact. There was no effect of giving either or, meaning that it's probably not dose dependent, just as long as you give a certain dose of estradiol. But nevertheless, there was a slight increase during this 5-year time, both in systolic and diastolic blood pressure. Liver parameters are often increased in the women that we see in the outpatient clinic. And we know from several studies, this is a study from London, just showing you that when you treat with HRT, there is a rapid fall in all liver parameters, emphasizing that HRT is also important for the liver. And also here, we don't see a window of opportunity, at least when participants are below the age of 50 years. Turning to look at the uterus, this has become much more important during recent years because so many women now opt for oocyte donation. And this, the one study from 2011, just to show you that the uterus in many young adult females with Turner syndrome have a smaller uterus that is not large enough to carry a pregnancy. And even despite long-term high-dose 17-beta estradiol, some uteri remain too small to carry a fetus, and it's important that you look for this before going on to try a oocyte donation. So there are a lot of questions relating to HRT still remaining, because we don't know which dose is optimal for bone mineralization, uterine growth, cardiovascular status, blood pressure, cognitive development, and liver function. So we still have to do a lot of research in order to get these issues solved. There's also important issues when we talk about morbidity and hormone replacement therapy, because we realize that several women are not receiving appropriate HRT. And in this Danish registry trial, we looked at all Turners in Denmark, and when we studied the 45X group, we realized that a minority of these patients were not receiving any hormonal replacement therapy. And we could see that HRT was actually protective for a number of diseases, and there were trends for a protection for a number of other diseases. As you can see here, there was less stroke, cases with stroke, less cases with diabetes type 1 and osteoporotic fractures in the group that was receiving HRT, while the group that was not receiving HRT had a higher frequency of these diseases. And there were trends in that direction for a number of other diseases. And there was also a reduced use of medications, antidiabetics, antihypertensives, thyroid hormone, and bisphosphonates, and so on. So just emphasizing that HRT is really important in Turner syndrome. We also looked at the number of cases that were not receiving HRT, and rather surprising for us, we saw that a number of patients were really not getting the appropriate HRT, as you can see in this figure. You could also see that even though we don't recommend contraceptives, a number of patients were actually receiving contraceptives. This is something that we also know is happening in other countries, and we don't recommend that anymore, and we think that it is better to give natural 17-beta estradiol. So returning to the effects of hormonal replacement therapy, we think we can say that there are a number of important organs that need HRT, appropriate HRT, and I have listed them here in this figure. The central nervous system, there's still a lot of studies to be done here. We know that it's important for liver metabolism. We know it's important for normal sexual function. We know it's important for weight and metabolism, especially keeping up muscle mass and keeping fat mass down. We know it's important for lowering blood pressure and so on. And we might even be able to see that it also has positive impact on longevity. I think we can also say that there is no increased risk of breast cancer, which has been discussed in Turner syndrome. The data that we have from Denmark actually show that breast cancer is very, very rare in Turner syndrome and is actually rarer than in other women. So that shouldn't be a worry in Turner syndrome. The heart plays a special role in Turner syndrome, and there are lots of congenital malformations, as you know, bicuspid valves, coarctation of the aorta, and other rarer abnormalities. And this is of course something that we have to look for, and that's why we have a close working relationship with our cardiologists and the MRI department that performs MRI of the heart and especially the aorta, in order to avoid having aortic dilatation and dissection. We know that congenital malformations in any given Turner syndrome population is very frequent, especially if you look for it with MRI. You'll find that many have a malformation. These are some Danish data, but there are other American data to show the same, that bicuspid aortic valve, of course, bovine aortic arch, coarctation, elongated transverse aortic arch, and other abnormalities are very frequent. We also know that the occurrence of one malformation often is followed by the occurrence of other malformations. Quality of life is also an important issue in Turner syndrome. This is a French study of young women with Turner syndrome, and in this study they noted that very few, only about 30%, had sexual intercourse by the age of 20 years versus 85% in the general French population at the same age. They noted also that the later puberty had been induced, the later or not at all had these Turner syndrome females had sexual or encounters or romantic endeavors. So that stresses the need to induce puberty, I think, at an age appropriate, at an age that is appropriate. This is a Norwegian study basically showing you similar results, namely that females with Turner syndrome have lesser or no sexual experience than the general population in Norway, female population that is. Again, you could say that here you probably have a window of opportunity, because the French study showed you that age-appropriate induction of puberty was necessary to develop a normal sexual life, or a more normal sexual life, I probably should say. But we still don't know whether we need, we can have this effect also, for instance, on the brain, the uterus, and so on. So there are a number of issues that we have to examine further there. And there's also the question of low androgens, which are really much lower in Turner syndrome by about 50%. And does that play a role? This is not clear yet. So I will end by showing you the setup that we have at our hospital, where we have the adult clinic. We also have the pediatric clinic, and we work together with the pediatricians, but we work together with a lot of other people. We work together especially with the cardiologists, radiologists, the gynecologists, the plastic surgeons, the clinical geneticists, and so on. And we have a continuing follow-up process during adult life in order to, for instance, catch the development of endocrine disorders, autoimmune disorders, keep bone mineralization up to speed, and so on. And in order to have that, we need to have a good working relationship with a lot of other disciplines, and we also do research along the way in order to answer many of the questions that I have posed in the in my talk right now. So I will end my talk here and take questions from you. So please, if you have any questions, I'd be happy to answer them. Are there any questions from the... Yes? Okay.
Thank you, Klaus, for your presentation. If people want to ask questions, please raise your hand via the toolbox, and then we can give, we will unmute you.
There's one here. Okay. Violetta?
Yes, Klaus, thank you very much for your very nice presentation, raising so many further questions in these patients. One of the things that our young adults are always questioning is the preservation of oocytes or gonadal tissue. Can you tell us a little bit how you do it at your center? What do you preserve? Which age do you prefer? Is there any protocol for that? Thank you.
Well, we are actually starting a protocol, and we in that protocol we are going to start with from 5 years and up until 18 years of age. We're probably going to adjust that while doing this protocol, and I think it's important that we do it in a protocol because I think it's necessary since we don't know the outcome yet. But it's going to be a nationwide protocol, and we're going to invite everyone with Turner syndrome to participate in this if they have the wish for it. And that means that we also have to talk with the parents, because when you're 5 years old, you cannot decide that on your own. So that's where we are right now. And then we don't, of course, know what the outcome will be, and we will not biopsy everybody if we are sure that there does not seem to be any viable ovarian tissue. We will not do anything. We will tell the parents and the kid that there is probably not a chance for fertility, but if we think there is a chance for fertility, we will biopsy. So that's going to be a protocol study, you could say. We also have a lot of scientific questions that we would like to ask, but it's also going to be a practical protocol that we're going to run that way.
Thank you. Looking for the results and their publishing as soon as possible. Thank you.
It's going to take a long time. I'm worried. Yeah. Okay. Are there any others?
Klaus, for the moment, there are no other questions.
There is one more, Alessandra Gambi.
Yes, she just raised her hand again.
Yes, hello.
Yes, hello.
Hello, my name is Alessandra Gambineri from Bologna. Thank you for your overview. My question is, what about tumors, neoplasm in this population? Because we have a population that we have that we follow after pediatricians of our university, and we are starting to find many cases of tumors. in the adult life. So my question is if you have also cases, and which is your suggestions about the protocol to monitor these patients in the best way?
Yeah, as I said, I mentioned that cancer is not of special concern. Females with Turner syndrome can also get cancer, no doubt about that. But as far as we can see from the data that is available, and there are good data from the UK, from Sweden, and from Denmark, nationwide data from all these 3 countries, there doesn't seem to be an increased risk of cancer in general. But there are a couple of certain cancers that might be seen a little bit more frequently. Especially, there seems to be an increased risk of meningioma of the brain, of course, and there also seems to be a decreased risk of breast cancer, which is really interesting. That is found in all the studies that have been presented so far. So we don't have a cancer surveillance program, and we don't think there is a reason for this. Of course, you should be vigilant of cancer in general, but not of any specific cancers, I would say. Okay.
Thank you.
Yeah. Are there any other questions? Otherwise, I think we will turn over to Arlene.
Everybody, Klaus, thank you for an excellent presentation. It was very good, and you raised a number of things that I think are particularly interesting. But from many of the Turner support groups worldwide, the diagnosis is a big issue for us, and obviously accessing HRT is a bit of a problem in the world at the moment. But obviously, for the women, it's very important that they get the treatment. So I just wanted to share some information about myself, who I am, for those of you that don't know me. So my name is Arlene Smythe. I'm Executive Officer of the Turner Syndrome Support Society, and here is my email and the website address. I'm also President of the Turners International Group, and there is their details. Most proudly, I am the mother of a daughter with Turner syndrome, Kylie, and she was diagnosed when she was born. And then I am also a Eureka board member, part of Work Package 5, which is Patient, Parents and Ethics. Very important, looking at registries, and we hope that that will develop in the future. And I'm also part of the Endo-ERN, part of the Sexual Development and Maturation group. I'm also proud to be part of the Rare Conditions Office in Glasgow, and I work with the families there to share stories, help them access support, and raise awareness about rare conditions. And then I've also worked with Klaus and many others with the clinical guidelines, which I think are just wonderful and incredibly beneficial, both to yourselves as doctors and to many family members. And there is, for your information, there is a patient-friendly guide, which is available on our website. I've put the guide there. And then we also, as a result of the guidelines, have produced a paediatric health checklist for the management of Turner syndrome, with paediatrics on one side and adult care on the other. And we think that's particularly useful, and we'd be more than happy for any other country to use these guides to assist them. So I am more than happy to answer any questions you've got, and we can have a discussion about any topic on Turner syndrome. You see me? Has anybody got any questions? Hello?
Arlene, at the moment, there are no questions.
Okay.
Please raise your hand if you want to ask a question to Arlene.
So, will I ask Klaus some questions?
Sorry, Arlene, what did you say?
Will I ask Klaus some questions? We can have
yes, you may.
Okay. So, Klaus, one of the questions that I was thinking about was how do we improve diagnosis? And this is something we hope to achieve some discussion around at the international conference in July for families. But other than through the heel prick test, do you think there's another possibility?
Certainly, there are the fact that many are diagnosed now intrauterine. That is one place where you could say that we could increase diagnosis. What we can see in Denmark, at least, and I think that is also happening in other countries, is that a lot of families that get the result back that they're going to have a Turner syndrome baby, they actually opt for abortion. So that's not necessarily going to lead to more live Turner syndrome babies, but during life, I'm afraid that I'm a bit pessimistic, because I don't see that we are diagnosing women with Turner syndrome better anywhere in the world, actually. So I think that we are missing an opportunity to improving the lives of all the ones that are diagnosed late, and I don't think that there is any other way than using the heel prick, really. I've been in the Turner syndrome field for too many years, and I've seen that it's so difficult to diagnose patients early on, even though I've repeatedly met many pediatricians that have told me that they diagnose all Turners. I know that is not the truth, so I'm rather pessimistic, and I think only the use of the heel prick test would bring about a diagnostic rate that is acceptable.
Yes, I too have concerns about the termination rate. It seems very high, and we certainly think that's due to misinformation. And we produced an information pack to give out to midwives to help with more accurate information, which is available on our website. It's called the Bungo Pack. But there is a new test. I don't know if it's available in Europe, but it's called the NIPT test.
Yeah,
it's a non-invasive test. And what we're finding is that has come about a number of diagnoses, but again, sadly, the majority must tend to be terminated, and we struggle to understand why that happens.
Yeah.
Information. Does anybody else have experience of tips to diagnose? Can anybody? I don't know if I can show you my screen. Can you see the photograph on my screen?
Yes, Arlene, we can see your the photograph. Yes.
Photograph. So this photograph is taken at conference, and these are all girls with Turner syndrome, with the exceptions of one or two. This young girl's a sister, and obviously that young chap's not got Turner's, and he's one of the volunteers. And so one of the things that we think would assist doctors with the diagnosis is to understand that the vast majority of the girls look quite normal, and you know, the ones that are more severely affected and have a slightly more obvious phenotype, they'll be picked up early on. And this young girl here, Emily, she was diagnosed actually through her ENT specialist, but she was already, I think, 12. And this young girl here, Grace, she was 10 when she was diagnosed and had to almost immediately go for surgery for coarctation. So it is very important to get the diagnosis, especially to care for their heart. So I just thought I'd share that photograph with you.
Okay, if there are no further questions.
No, Klaus, for the moment, there are no further questions.
But then I think we should end the webinar here.
Yes, we can. Thank you very much, Klaus and Arlene, for your presentations and hosting the webinar. And thank you, the attendees today.
Okay.
You will receive an email so you can view again the webinar, because this is recorded. And if you have any questions, you can contact us as well. And that's in the details are in the email that you will receive tomorrow.
Okay. So
Thanks.
I don't know if people can see this, but this is the patient-friendly guideline, which is available on the website. And this is the health checklist, which is again available on the website. Okay, so I hope you find those useful.
Thank you, Arlene. Thank you, Klaus.
Thank you.
Okay.
Nice to talk to you.
Okay.
Thank you. Bye.
Bye.